If you look back at some of the initial research in sexual function, Masters and Johnson, they assumed that the person was at a level of positive desire from the beginning. They didn't even take desire into account at all.
So many people I talk to who've lived with pain during sex tell me some version of the same thing, that their desire just disappeared. And alongside that, there's often this quiet sorrow and a lot of self-blame, this sense that if your libido is low, it must mean something is wrong with you as a person. But what if that's not it at all? What if low desire isn't a personality flaw or a verdict on you, but a set of bodily processes we're only now beginning to understand and actually treat? It was only very recently that we got the first drugs for low desire in women, more than 30 years after Viagra came to the market. And that gap alone tells you how little this has been taken seriously. Today, I'm exploring all of this with one of my favorite doctors in the space, Dr. Babb. We get into what desire actually is, how it's different from arousal, why pain has to be addressed first, and what neuroplasticity has to do with desire coming back. It's the kind of conversation that helps you understand your own body better, and I think it makes it fundamentally important for that reason. Enjoy the episode. Corey, welcome back. I'm so glad to have you here again on the podcast.
Well, I'm very happy to be here as always.
So I think people listening may know that I'm one of your biggest fans. Not only are you one of my favorite experts within sexual medicine that I've spoken to so far, but you also write this Substack that I think is some of the most clear, thought-provoking writing on sexual medicine out there. And you have this
Thank you.
Analytical, inquisitive mind that I really appreciate because you have the ability to kind of zoom out to the wider so what of whatever you cover. And one of the things that you've been writing about recently is desire and arousal, which is what I wanted to talk to you about today. So before we get into the science of it, what made you want to write about this topic? Like, why does it matter?
Well, yeah, I mean, I think that when you talk about kind of these very tangible aspects of sexual function, they're also some of the most misunderstood. We hear patients all the time that basically use the words interchangeably. And they're two very different processes. And I think that that's something that, one of the reasons I wrote about these in these kind of articles to really help patients understand, or whoever's reading it, that they're completely different. And yes, they work in, together, but, you have to address them individually, especially when patients come in with concerns about those different things.
Yeah, I appreciate that. And I think from my perspective, it can feel quite mystical or
Mhm.
elusive. I think these
Sure.
topics, and I think we all, maybe especially as women, have like internalized this idea that if we, for instance, experience low desire, that's like a personality thing, like a personal flaw, rather than
Right.
something you can actually explain or at least explore through science. And I think that's why I love reading your Substack series, because it goes into more of what we know on these topics. And
Oh, thank you.
yeah, it's really interesting. So I wanted to start simply because you alluded to it there already. A lot of people use these concepts of desire and arousal interchangeably. And you've made the point that they're not the same thing. Can you just set
Mhm.
the record straight at the beginning?
Yeah. So desire basically is the want to engage in sexual activity with someone else, with yourself. It is literally that desire to do so. Arousal is how the body responds to that desire. Desire is mainly in the brain, and arousal takes kind of and breaks it almost in half to where you have both a brain driven portion, but then obviously the body responds to that too. So I kind of say it's the want and the how. That's the way to separate them. Probably the simplest.
And so is it desire kind of feels like that urge, the like almost like the instinct that you
Mhm.
would like to engage in sex, but then arousal are like the bodily processes. Maybe you can go into some of those just so we have it clear in our mind exactly what arousal is.
Sure. So, if you think about it, if you find someone, let's say that you are in a relationship or you have whoever that you want to engage in some sort of sexual activity with that bodily response that starts. You can feel maybe your heart starts beating a little bit differently, your breath starts kind of changing. We know that from a pure physiologic standpoint, our pupils dilate. We get a shift of blood out from our necessary core organs into our genitalia. And so that's what's going to cause, in someone who has a penis, a penile erection, someone who has a clitoral erection, with the vagina, that influx of blood coursing through that tissue actually is enough to push this substance called a transidate out of the cell and into the vagina itself. And that's what contributes to vaginal lubrication. So a lot of it is based for arousal on blood flow. And so conversely, when you have issues with that blood flow, then you can have issues with arousal. But I think the best kind of physiologic things, if you like, the penile erection is probably the most culturally understood, if you will, kind of representation of arousal. You can see that in antiquity and art. I mean, it's everywhere, but that is arousal. You can have someone who has a penis, who has an erection, and they could care less about having sex at that time. And so that's one of the easiest ways to differentiate the two, I
Mm,
think.
that's really helpful background. And I want to start with something you described briefly in the previous episode that we did together, which was on Botox therapy.
Mhm.
And you mentioned this concept, which I found really intriguing. You called it a cascading model of sexual dysfunction. Can you
Mhm.
walk us through that model and how it affects basically how you assess a new patient coming in your door?
Yeah, so it came off of this image I found basically of this kind of like a water feature, and it had multiple tiers of it. And if you can imagine the four domains, or what we call them, of sexual function. So that's desire, arousal, pain, and orgasm, basically, and how those all fit together. So someone who presents with an issue with desire, I've in a relationship, I find my partner very attractive, but I have no desire to engage in sexual activity with them. We kind of step back and we look to make sure that there isn't anything else going on kind of in this waterfall model. So at the top of it is pain. If pain is there, we always treat the pain first. It doesn't matter how aroused you get or how good the orgasm is, if you will. If it's going to hurt in a way that you're not looking for it to hurt, you're not going to want to do that. And I kind of use the example a lot. I don't want to slam my hand in a car door. Like, I know that is going to be painful, so I'm not going to want to do that. After that, you kind of look at, is this person going to respond to sexual activity? So in the case of people with vaginas, are they getting adequate vaginal lubrication? Do the things feel dry? Are they not really feeling much at all? Then you want to address that. After that, we go to orgasm. Are you getting some sort of, satisfaction, a climax, and that sexual experience? And obviously, there you can have very robust sexual intimacy with someone and not orgasm at all. But for a lot of individuals, they view that kind of as this is part of the experience, and if it's not there, this may look like work, especially if they're having to put a lot of time into it. And then finally, if all of those other things are working, then you can address desire itself.
Yeah.
So,
Yeah. I find this so helpful to understand because sometimes I feel like we can, desire is often the most visible thing, right? It's what the
mhm,
relationship feels and what the person itself feels. But your model says that you actually have to, it's actually the last thing you look at
right.
after having looked at all those three areas of sexual function: arousal, orgasm, and I forget what the third one
Pain.
was now. Pain. Yeah, of course.
Yep.
Pain. So what you're saying is that even though desire is often the presenting complaint, it's almost always the last thing you address.
Right. And I think it's kind of, in a way, the most socially acceptable of sexual conditions. It's not, I mean, we see patients that come in all the time, and granted, I know we're a, specialty clinic, who are complaining of low sex drive, but rarely do they come in as the main complaint, it hurts when I have sex, or I'm not getting aroused with it. It's the desire is what brings them in. And in the case of, partnered relationships, often there's that feeling from the other partner too, if it's like, well, if I, with my wife, like, hey, do you want to, kind of have some fun time tonight or whatever it may be? And she's like, no, I don't really want to. If that keeps happening over and over and over again, to me, as one half of the partnership, it may be like that her desire is not where I want it, or that's the issue. But in reality, maybe she's having pain, or maybe she's having other thing, and she's using that "I don't want to" as a way to not then have that subsequent, sexual encounter that could lead to those other concerns.
Yeah. And is it the case then in your clinic that you sometimes the kind of presenting concern will be, as you say, I have low sex drive, and then actually you discover that they are dealing with pain during sex, but they're not really viewing that as something that isn't normal or that could be dealt with. They're kind of just do you find that happens?
No, I do. I think, and that's, this idea of this suffering individual sexually that like has been told, well, sex is always going to hurt, or it's supposed to be painful. And even, in 2026, we still have patients that are like, well, I just always was told that's what it was going to be like. And that was part of my burden to carry, as a woman, was that I was not going to enjoy sex. Sex is for the enjoyment of my, in a lot of cases, male partner, my husband, whatever it may be.
Yeah. Oh, we need a revolution to change that. I can't believe that
Yeah.
that's still the case.
Yeah. Very much so.
It's yeah, it's really fascinating. And yeah, I think I'm just happy that we have that explanatory model, because I think we also, like, as you say, maybe a lot of people experience pain over a long period of time and they just think it's normal, or that's how it should feel for a woman having sex. But I think also the piece around like pleasure for women is also
Mhm.
something that has been, neglected a lot over time. So it makes a lot of sense that if you have that repeatedly, then it's like a reward system that works against you, right? You're not going to have desire for something that just, as you say, like doesn't really give you anything. Maybe it gives you pain, or just it doesn't give you any pleasure.
Right. And well, and that gets into the whole like the neuroscience of this. Our brain has this kind of capacity in what's called neuroplasticity to learn and associate behaviors with certain, kind of results. And so even if you take someone who has had kind of, if we use vaginismus, like we talked about last time, they have been unable to have penetrative activity. And now they go through whatever process it is. They're now able to engage in penetrative activity. It's non painful. They will often still have very low levels of desire, if they have any desire at all, just because their brain has learned to associate sexual activity with discomfort. And even when you take away that discomfort, the brain then has to still relearn again that, hey, this can be enjoyable.
Yeah, yeah, yeah. And it sounds like, if I'm understanding this model correctly, it also has kind of implications for expectations, in terms that desire may take the longest to return, not because it's necessarily like the most stubborn problem, but because it's waiting for everything else to kind of fall
Yeah,
into place, which I think maybe can be reassuring to hear, because we place so much emphasis on that need for stable and high desire. But you have all these like contingencies resting on that being the case, right?
right, exactly.
Okay, so that's the waterfall: pain, arousal, orgasm, and then desire last. And I want to stay on desire for a second, because I think there's this assumption underneath it all, right? That real desire should just show up on its own, unprompted. And if it doesn't, you've done something wrong, or there is something wrong going on. Do we have any idea where that idea actually comes from?
Yeah, and so a lot of this, if you look back at some of the initial research in sexual function, so Masters and Johnson, back in I think it was 60s or 70s, I can't remember, started doing this research. They assumed, and if you look at kind of their graphs of human sexual function, both male and female, that the person was at a level of positive desire from the beginning. They didn't even take desire into account at all. And so that's, I think, where that kind of cultural idea began, and that like, okay, well, that's there and it's going to just do its thing, and that's why we need to treat that, first, if all these other things, before we do anything else. Rosemary Basson then proposed this model later on, saying that really individuals are starting from a position of sexual neutrality. There has to be something that triggers that spontaneous desire. And for a lot of individuals, it's emotional connection. It's a feeling of safety, a feeling of courtship, whatever it may be. Rarely is it something that the patient becomes aroused and then is like, well, now I want to have, like it often doesn't kind of flip into that way. But I think that that's a very important point in that we have to understand that, things do need to line up for desire to occur. Rare is it that it's just you just kind of are walking down the street and then are like, oh, actually, you know what I want to do? I think I want to go have sex right now. I mean, maybe you do. And if you do, that's great. There's nothing wrong with that at all. But for especially people in coupled relationships, if they've been in it for a long time and you're out of that kind of initial dopamine high when you just look at the person and it's all about, let's kind of go and get together in that way, there has to be some activity that starts that desire, wheel turning. And often that comes from that emotional connectivity, those feelings of kind of connection in that way.
Yeah, okay, interesting. And so, because often we distinguish between like spontaneous and reactive desire, right?
Mhm.
But what you're saying is that our understanding of that spontaneous desire has kind of evolved over time as well. Am I understanding that correctly? That like in the Masters and Johnson's piece or in their work, they kind of just assume that
Right.
individuals should have this baseline desire that is just there kind of humming in the background like an
Yeah.
instinct. But then over time, we've understood that actually you can kind of codify more of what is it that actually makes that so-called spontaneous desire kind of emerge. And as you say, it's often tied to emotional like connection.
Right. And especially, I'm a gynecologist by training, so I see, 99% of my patients are people who identify as women. And for so many, for them, there is that need for that emotional connection, that kind of emotional intimacy feeds into the physical. And so when you have a person, I remember this patient very much from when I was on faculty at Oklahoma State. She came in and her husband worked in a different city 5 days out of the week. They had 3 kids. He expected when he came home on the weekends that the house would be clean, the kids were taken care of, they would have sex pretty much, Friday night, Saturday night, and Sunday night before he went back to work. There was no going on dates, there was no courtship, this was just kind of the expectation. And she's like, she came in saying, okay, my main complaint is I have no sex drive. And it's like, well, okay, well, why would you? Where is the emotional connectivity? Where is that intimacy that's there that's kind of driving this? You're expected to kind of be this, workhorse, if you will. And then just your husband comes home and it's like, all right, now we get to do this. And then he's going to go off again. And there's a lot of kind of like, what is she getting out of that, if you will? But there has to be something that is driving it. Rare is it, especially the person who's in, longer relationships, if they have children, other things, life is going on, that spontaneous desire is there all the time, or even the majority of the time.
Mm, okay, interesting. And there is a model that you wrote about on your Substack, which I found genuinely interesting. This dual control theory. Can you
Yeah.
explain that?
Well, so it gets into basically kind of like what part of the brain is kind of in charge of things. And if you imagine that we have part of our brain that is inhibitory and then another part that is excitatory in terms of sexual desire. And this is really where neurotransmitters as chemicals kind of come into play. The two main neurotransmitters that affect sexual desire are serotonin and dopamine. And serotonin is normally kind of thought up as our everything is relaxed and I'm fine and I'm safe and I feel good and I just kind of want to, just chill out. And dopamine is our I want to go do stuff. I want to eat that cake. I want to have sex. I want to go skydiving. It's very excitatory and wanting to do things. And so there typically is this kind of interplay between the two. And depending on the situation, one is kind of, driving, if you will. And so the issue then becomes when, one, either your gas, if you will, with your dopamine, or your brake with the serotonin, depending on if one is the predominant neurotransmitter that is there all the time, you're going to kind of lean one way or the other into potentially hypersexuality or a complete lack of sexual desire in very extreme states.
And so, okay, so just to make sure that I understand it, we kind of have this accelerator, which is the sexual excitation system, which is tied to dopamine, and then the brake, the sexual inhibition system, which you say is predominantly tied to serotonin.
Serotonin.
I think it's interesting the point around serotonin because I would also assume because I envision like the inhibition system as like very tied to fully pressing the brake, something is wrong, like there's danger, something like that. I would imagine that if you have that state of everything is fine, everything is, just good with like a normal serotonin level, then that would also be a state where you would want to engage in sex or like, but do you follow me? Do you?
No, I do, and that's kind of that's a very common kind of question with it, because like you said, if everything's feeling good, why don't that's the perfect time to do things, right? And I think the main difference with that is that you are absolutely correct in that when our body perceives that things are safe, it then can allow arousal to happen. And that's kind of, we haven't even talked about autonomic nervous system with this yet, but you have to be in that parasympathetic, that like everything is nice and relaxed to get blood flow to your genitalia. If you're in the sympathetic, I'm running from a bear, I'm being chased, blood is going to go to your heart or to your lungs or places that it needs to go. But, if you think about the most common sexual side effects from medications in the like SSRI class, like antidepressants that are increasing serotonin levels, it's low sexual desire. The second most common is orgasmic dysfunction with that. And medications that are used sometimes to treat low sex drive, like whether that's flibanserin, which is Addyi, which is a inhibitor of the inhibiting aspect of serotonin and an exciter of the excitatory aspect of it, or Wellbutrin, which is a pure dopamine medication, are really promoting that excitation model of things. So, I kind of, it's also, there was some work that's been done with cannabinoids, like in marijuana, and how that works on sexual function. And a lot of patients in these studies reported that lots of marijuana usage often actually decreased their overall sexual desire. Now, if they had sex, they may report better orgasms and better, response time, and they can enjoy it more. But for a large number of patients in these studies, one of the things they said is, I don't have the desire to engage in that. And it could be because some of those terpenes in the THC are raising their serotonin up and giving you that, I'm just going to sit here and, get the munchies or whatever it may be.
It's interesting. It's like I'm so chilled. I'm so happy that I just can't be asked, basically.
Pretty much. That's kind of the way I think about it. Yeah.
Yeah, but okay, so if I'm understanding you correctly, then you're saying that what drives low desire can it both be then like a weak accelerator and an overactive brake?
Totally. Yeah. And that's actually what we would see in like, your typical patient who's on some of the SSRI medications. They are very serotonin driven. They're not depressed. They're not feeling anxious, but if you take that to an extreme, a lot of those patients feel very numb, and there's like, I just don't care. Well, their dopamine levels can often be very, very low, with that. And so you don't have that urge to do things, if you
Yeah.
will.
Okay, interesting. And is it I mean, can we talk about this excitation and inhibition system then in the context of pain? What do you see there in terms of patterns if someone has pain over time, sexual pain over time?
Yeah. So the biggest thing, obviously, is going to be that it's going to lean towards non or like a lower level of desire, unless, and here's our kind of caveat, there are people that very much enjoy pain with sexual activity, specific types. And for those patients, that, the endorphins that are released with pain and things like that can be very exciting. So just that is a subset that we're going to put over here. When we talk about people that are not, enjoying the discomfort that they're having, pain from pelvic floor dysfunction, vulvodynia, whatever it may be, you don't obviously from a neurotransmitter side of things have this nice serotonin release. You're not really getting dopamine release though either, because you're not really enjoying it. And furthermore, the more pain that is going on, the brain is viewing this as a threat. And so it's doing what our body has been kind of evolved to do in response to threats. And that is kind of activate that sympathetic or fight or flight kind of reaction. If you think about, like we kind of talked about last time, in patients with, grade 3 and above vaginismus, their legs will lock. They'll lift their, buttocks off the exam tables. You're trying to do things. They are not going to let anything, go inside them because of the response that it triggers, right? That is a pure autonomic fight or flight type reaction. Their heart rate's going to go up. They're going to start sweating, like all the things. Blood's going to be pulled out of the genitalia, and it's going to those organs to allow us to run from the proverbial, bear.
Mm,
Yeah.
exactly. And how do you then start breaking that cycle? How do you think about that?
So you've got to, first of all, kind of take care of the pain. That's where you kind of go through the waterfall aspect of it. And doing that, you are also working on that neuroplasticity. So like for our vaginismus patients, if we're having them do dilator therapy, that's one of the reasons that, when we do the kind of the PASIC protocol, they're wearing these dilators for multiple hours a day. They're sleeping with a dilator in. It is consciously and subconsciously training the body, and therefore the brain, that something touching this tissue is not a danger. And so then once they can downregulate that, they say, okay, I can now have penetration. Then we can start to kind of address, okay, what feels good to you? Because that's another question that a lot of people have never been asked, especially by a healthcare professional. Tell me what feels good to you with sexual activity. I can think of many of my colleagues who would be very uncomfortable asking that question, who aren't sex med, providers.
Yeah, interesting. Yeah, it's one of those things that I think it kind of feels outside of medicine almost, and something
Hmm.
that is like very personal. But in
Right.
this context, it definitely matters, as you say, right?
Yeah.
If the goal is to increase desire, reduce pain over time, then that is important part of the equation. And now a quick word from the partners who actually make this podcast possible and free for everyone. This one's for you if penetration or insertion has ever felt uncomfortable, especially right at the opening. There's a reason that spot can be so sensitive. The vestibule is one of the most densely innervated areas in the entire body, which is exactly the problem Pelva set out to solve. Their Hydroslix vaginal liner sits right at the vulva and vestibule during penetration and adds a soft cushioning layer, so the pressure spreads out instead of landing straight on those sensitive nerves. The founder Kelly always says to think of it like a shoe sole, but for your vulva and vagina. And speaking personally, having that bit of protection between me and that sensation is part of what helped me start to feel safe and comfortable in that space again. And I cannot stop talking about ingredients, so I love that there are none of the funky ones in here. There's no fragrance, parabens, hormones, silicones, glycerin, none of the stuff that tends to set things off if you got any sensitivity down there. So if that sounds like something you're worth trying, head to pelva.com via the link in the description and use code TWTC10 for 10% off your first order. Okay, so a quick, honest moment before we carry on. This episode is also sponsored by me and my savings, and that's not a complaint. I decided to go full-time on this podcast because I believe these conversations need to exist and need to be free for the people who can't afford one more paywall between them and an answer. But free for everyone only works if it's sustainable, so here's how you can help me get there. The biggest thing is supporting the podcast directly. The link's in the show notes. And right now I'm running a campaign where anyone who becomes a monthly contributor to the world's tightest community gets some genuinely cool founding member merch as a thank you. So do go have a look. And if that's not where you're at right now, the next best thing is completely free and takes 30 seconds. Follow the podcast and leave a rating and a review wherever you listen. And just one quick note on that, on Apple Podcasts, people only see ratings from their own country. So in some places, this show looks like it has none, which it doesn't. But every rating you add helps another person find this when they're searching for a name for what's happening to them, and it also helps potential sponsors see the value of this. So support directly if you can, rate and review if you can't. Both truly keep this going. Okay, back to the episode. Okay, so that's kind of the how and the why, the brake and the accelerator, the brain learning and relearning. And I want to get practical for a second because there are only 2 drugs approved for low desire in women. Where did they fit into everything you've just described?
So it's, from a purely FDA, Food and Drug Administration standpoint, they are approved for the treatment of hypoactive sexual desire disorder, or HSDD, which is the most common type of low desire, and desire issues are the most common type of sexual dysfunction. So we're working on statistics there. Both of these drugs, they work on a little bit of a different way. So Addyi, is, like I said before, kind of a serotonin agonist antagonist. So it's decreasing your brake and increasing your accelerator a little bit. It really functions well as a way to increase receptive desire. I have not seen a patient who is on Addyi, doesn't mean they don't exist, but who is actively going out and being like, I want to have sex with this person I want to have, it's not turning them hypersexual. It's making them more like, yeah, that sounds like that could be fun. They're having spontaneous sexual thoughts. Maybe they're having more erotic dreams. It's kind of bringing it more to the forefront, if you will, kind of what's going on. Vyleesi, on the other hand, as a peptide, it's PT-141, it's bremelanotide. It's basically a big shot of dopamine. So Vyleesi is something that is going to say, hey, you and me, let's go I want to do this. And so that's the main difference. They both are attacking the condition, but from a little bit of a different angle. And that's why you can use both of them together. There's absolutely nothing wrong with doing that, It's just kind of when talking to patients, which subset do you feel you're more in? Do you, and with HSDD specifically, it's, I enjoy having sex. I often think to myself when I'm having sex, why don't I want to do this more? But left to their own devices, they would never seek it out, or they don't really think about it, or it's not something that is ever on their mind.
Okay, interesting. Is that how it's defined?
Yeah,
HSD?
so yeah, that's pretty much the definition of HSDD. So, you have to make sure it's not due to partner issues or other medical concerns. And we divide it into, whether it's lifelong or acquired or kind of different subsets basically. But with those 2 medications, it is for patients who have previously had a good level of sexual desire. They're bothered by it, and that's the most important facet for any aspect of sexual medicine. Are you bothered by this being there? And then, like I said, they want to do something about it. And then there's not something else kind of going on that could be the cause of it, like they are on chemotherapy or their partner, with a male partner has their uncontrolled erectile dysfunction or things
Hmm.
like that. So, yeah.
Okay, understood. And these 2 drugs, it's a really helpful explanation of how they differ. Do you see them playing a role when someone is either currently or has in the past experienced pain during sex?
Yeah, no, I definitely think it can be, especially once you've gotten the pain taken care of, there are good ways to kind of reintroduce that and kind of push the brain towards it. Because even though they're FDA approved
Hmm.
for HSDD, they're still going to work even if that patient doesn't necessarily have DD per se. If the issue is related to those neurotransmitters being whatever they are. And so I think that is very important because in our example, a patient comes in and she has terrible endometriosis and she has significant pain with sex. You can put her on as much Addyi and Vyleesi and testosterone and whatever else you want to do.
Mm.
It's not going to change anything, right? So that is where they come into play, is kind of, if you've taken care of all the other aspects of the waterfall first, or that patient really their only issue is that HSDD, which is definitely a possibility.
And I want to tie it back again more concretely to potential listeners of this podcast who, may be at the stage where pain is more or less resolved, but they are still struggling with that desire. And tying it back to this like neuroplasticity concept, how long do you need to basically nurture that desire by trying to do things that promote arousal and pleasure? Like how do you think about that?
Yeah, it's that there is your crystal ball question
Yeah.
of, how long do we do this? And
Yeah.
I wish there was a definite we know that, like, so for instance with Addyi, we do know kind of that, if patients are on that and that's something they take nightly for 8 weeks,
Mm,
if you have not noticed any change at all by 8 weeks, then you stop it. You're not going to respond to it. Now, does
mm,
that mean that they just didn't, tolerate, or they didn't respond to the medication? It wasn't given for the right thing. Those are all different kind of conversations. But I would argue that's a really good benchmark that you can use if you are actively trying to do things to rewire your brain.
mm.
You can't just take away the endometriosis, let's say,
Yeah.
and then expect someone to just bounce back. I mean, it can happen, obviously, and there are people that do. And sometimes it's these kind of breakthrough moments where they're like, oh my gosh, I had a pleasurable sexual experience. I want to have that again.
Mm.
And that kind of starts that pathway. But getting over that hump, no pun intended, you know, can be something that can take a little bit of work. And this is also where sex therapists can come in actually very, to be very handy in addressing those other ways of, discovering
Mm.
pleasurable sexual activity.
Mm, mm. I want to hear what do you think is like exciting or intriguing new research or new thinking around how we understand, especially female desire, female arousal? Like, is there anything that you think is particularly interesting that's kind of being focused on right now? Any new ways of thinking about this?
Yeah, there's a company that was, and I'm not gonna, I don't own shares in this company or anything like that, but they were working on this drug for schizophrenia. And it was really interesting in how it was working, because it was working on dopamine and it was also working on serotonin. And it's literally like if you took Wellbutrin and mixed it with Addyi, like that was the pathway it was going down. And I actually reached out to the CEO of the company and was like, "Oh my gosh, I think you have something here." And he was like, "Yes, I think we do too." And then I don't even know if the market is the market, and the company got delisted and whatever. So we'll see. But so there are things like that if we are willing to do the research. And I think that's part of it. If you think about it, there are two drugs. We have mentioned the only two drugs FDA approved for low sexual desire, right? That's crazy. We have lots of medications for arousal disorders, but not specifically for women, unless you're talking about vaginal, either hormone therapy, or in the case of Dare or Dare, I don't know how they say their company. They have a drug coming out called Dare to Play, which is a topical sildenafil, which is the active ingredient in Viagra. It's a vasodilator and it's a cream. And this has been compounded for a long time, but they've kind of standardized it. But, we don't have any medications to treat orgasmic disorders. That's kind of the final frontier, if you will, because people are like, well, orgasm is, ooh, we don't want to talk about orgasm. That's that you want, something that makes people feel even more uncomfortable is, tell me about your orgasms, So so I think that the things that will need to happen moving forward is kind of breaking sexual medicine out of this kind of closeted niche. Because you think about it, sexual activity, even according to the World Health Organization, is a fundamental human right to have a sexual experience that is consensual, that is pleasurable, that is basically like, kind of protected. And, reproduction aside, which obviously we have to basically have sex unless you're going to do, some form of AR, assisted reproductive technologies. Like, it should be something that can be spoken about and enjoyed and whatever. And this is kind of a little bit of a soapbox, but Viagra, when it came out, I mean, it was huge. And previously, you had impotency, right? That was the diagnosis. No one wants to be impotent, right? That sounds bad. So what did Pfizer do? They took and they changed it to erectile dysfunction. Okay, so there's something that can be fixed, because the name implies there's some function to it. And the commercials they made it sexy. They had these very attractive women talking about, like, how their partner's using Viagra, and now they can look forward to this whole, I mean, like, you're like, "Yeah, I want that. I wanna have what that wants," at least here in the US where, it's a whole different world in terms of pharma commercials and everything. We have, I've seen some billboards for Addyi. I've seen a couple of ads here and there for Vyleesi, but I mean, it's not by any means standardized. Even medications for hot flashes, we'll go completely separate to like menopause. Stellis, who owns Vioza, put an ad in the Super Bowl. I think it was last year, or the year before. Huge American like commercials. People watch the Super Bowl for the commercials, and it kind of said, "Hey, there's stuff for hot flashes," but we don't do anything for women's sexual health. Like and that's not a jab or a complaint about the people that are in the trenches doing it, the scientists. It's just that it doesn't get a lot of funding. And even when it does, it's still hush hush because we have this idea that this is something that we either shouldn't talk about or we don't know a lot or whatever it may be.
It's so interesting to hear your views on this, and it resonates a lot. I did a recording a few episodes ago with this amazing writer, and we were talking about bringing a slogan to this space of bringing the sexy into sexual dysfunction. And I think
Mm-hmm.
we need to spread that wide and far when it comes to female sexuality in particular. So before we wrap, I want to make sure that we leave the listeners with a really clear core takeaway. What do you think is most important for them to understand?
I think the biggest take home message, to listeners, that they're two separate things. They can exist independently of each other. And if you have sexual pain, I would almost argue it's surprising to have high levels of desire, and arousal with that. And so just to understand that there are things that can be done, there is science behind this. This isn't, just some kind of witchcraft or whatever it may be. And there are people that know how to treat this out there and that can help kind of restore that sexual function for you.
Yeah, I think that's probably one of the most validating things that our listeners can hear because, yeah, as you say, why wouldn't you experience low desire if you've had pain for
Yep,
a sustained
exactly.
amount of time? Yeah. Corey, thank you so much for coming back. This conversation has been so insightful. I feel like my head is spinning a little bit from all the new information. So I look forward to listening back to this myself. How can people connect with you, follow your work, or read your Substack?
So I'm at Dr. Corey Babb pretty much across social media. My Facebook is Dr. Corey Babb, but otherwise it's Dr. Dot, and so that's on TikTok, Instagram, Facebook, and then on Substack too.
Perfect. Go check out his social media if you haven't already because it's brilliant. It's packed with really, really helpful information. So thank you so much, Corey. I really appreciate you coming on.
My pleasure. Thank you.
Thank you so much for listening. Like I mentioned earlier, if this one meant something to you, everything's in the show notes. You can support directly if you can, or just follow, rate, and review if you can't. It's truly how this work reaches the people who've been waiting for it. Thank you so much for listening, and I'll see you next week.